Welcome to the second video in the APGO Sexual Health video series. This video focuses on how to complete a comprehensive sexual history and perform a directed physical exam for sexual concerns. It will also briefly address treatment strategies. At the end of this video are a list of resources mentioned in this series. Incorporating a sexual history into well woman care is a way to increase your comfort level with discussing sexual health with your patients, as well as identifying and treating sexual problems or dysfunctions early. The sexual history can be included in a review of systems, in the section on social history, or in response to answers on a waiting room questionnaire. Ideally, it should be conducted before the physical exam while a woman is fully clothed to reduce her feelings of anxiety and vulnerability. This algorithm from the National Coalition for Sexual Health could be used as a starting point for the conversation. However, a clinician should tailor questioning to his or her practice style and incorporate open-ended questions. If the patient has a specific complaint, then more specific questions may be asked to better understand her specific sexual concern. If needed, a separate appointment can be made to discuss sexual concerns. The ACOG Opinion Report number 706 titled Sexual Health has a more detailed list of questions to ask during the sexual history, including questions on the 4 Ps: partners, practices, protection from STIs, and past history of STIs. Physical examination should be performed as necessary to evaluate for sexual disorders. This examination is usually based on a patient's complaints and reproductive stage of life. For instance, in a mature woman complaining of vaginal dryness with dyspareunia, pain during intercourse, you would perform a genital pelvic assessment to evaluate for genitourinary syndrome of menopause. In a younger woman complaining of discharge and dyspareunia, genital infection should be ruled out. In cases of dyspareunia, the genital exam should try to reproduce the pain. A detailed physical examination should not be dismissed if the patient is complaining of other symptoms. For instance, if thyroid symptoms are elicited during the history and may be associated with decreased libido, a detailed thyroid evaluation should be performed. Consult this table from Kingsburg and Janata for a more comprehensive description of the urogynecologic exam for conditions that can impair sexual function and assist in diagnosis. Referral for a full evaluation by a more experienced clinician is an option if you do not feel you have the skills to do a more advanced physical exam for sexual health issues. A number of interventions can be employed for all forms of female sexual dysfunction. We will now review global interventions and disorder-specific interventions. It can be useful to remember the Plisset model when discussing sexual health treatment with patients. It consists of giving permission to raise sexual issues, to use suggestions and try new things, giving limited information about a sexual concern, including clarifying misinformation, dispelling myths, and providing limited factual information, making specific suggestions about the problem in question, and offering or referring the patient for intensive therapy for the problem. Global interventions for all dysfunctions include ruling out underlying medical illness or anatomical pathology or conditions as well as medications that may have direct sexual side effects. You can and should also educate the patient about the specific sexual dysfunction and provide appropriate literature or handouts for her to review at her discretion. You may also prescribe medications for certain underlying sexual medical issues. Structured sexual tasks such as masturbation, self-stimulation using a vibrator, as well as simple sensate focus and mindfulness exercises may be helpful recommendations. These are typically included in marital and sex therapy counseling sessions and are a form of cognitive behavioral therapy. Sensate focus exercises eliminate orgasm as the goal of sexual encounters and instead focus on body awareness and the types of stimulation that makes a woman feel good. These exercises also initially avoid any erotic stimulation and promote good communication with a partner. Mindfulness is a technique to help a woman focus on what is happening and what she is feeling in the present moment and not judge her experience. In the next section of this video, we will review disorder-specific interventions. The DSM-5 combines desire and arousal disorders. Here we will review them separately, as lack of or low desire with distress is the most common female sexual dysfunction, and the term hypoactive sexual desire disorder, or HSDD, is still commonly used. One intervention for lack of desire is to educate patients that their experience is normal and that there are safe, effective treatments available. The knowledge that a woman may not feel spontaneous desire or may be motivated more by a desire for emotional intimacy with her partner than for sexual release may be all that is needed to improve her sex life. Books and other resources may also be helpful. Prescribing medication for lack of desire is another option. There is emerging data on the value of medication, and a woman should be offered medication without judgment as part of her treatment paradigm. Flibanserin is currently the only FDA-approved drug for generalized acquired HSDD and is indicated for premenopausal women. It is a non-hormonal agent that affects neurotransmitters that influence sexual desire. Clinical data suggests that approximately half of women with HSDD may respond to Flibanserin. Adverse events include dizziness, somnolence, and nausea. The risk of hypotension and syncope increase when Flibanserin is taken with certain other drugs or alcohol. Women should discontinue drinking alcohol at least 2 hours before taking Flibanserin at bedtime. The drug is only available under a risk evaluation and mitigation strategy, REMS, and clinicians must be certified to prescribe it. Testosterone therapy is another option for some women with HSDD, but currently is not FDA approved for treatment in either pre- or post-menopausal women. Interventions for arousal issues include educating a woman about the mechanics of arousal and genital engorgement, and conducting an instructional pelvic examination to help a woman identify the clitoris. Clinicians can also recommend reading materials and resources, mindfulness exercises, directed masturbation to help a woman identify what kinds of stimulation arouse her, and sensate focus exercises. Increasing stimulation with longer, directed foreplay or use of a vibrator during partnered sexual encounters may also be suggested. Another simple practical recommendation is use of over-the-counter topical arousal creams. These creams, which are rubbed into the genital area, are reported to increase blood flow to the clitoris and genitals and may result in improved genital engorgement. Although there is limited data on these products, they can be used successfully in some women. Skin irritation may develop in some, so an initial trial with a small amount, even in a non-genital location, is prudent. Women with female orgasmic disorder may lack body awareness about how to have an orgasm, or may have misperceptions that they should be having vaginal orgasms during intercourse, or simultaneous orgasms with their partner. Both, in fact, occur rarely. They may benefit from basic sex education accompanied by an instructional pelvic exam to identify the clitoris. Reading materials and resources can be helpful to increase understanding of anatomy and dispel myths. Clinicians should discuss methods of increased stimulation such as vibrators, as well as where and how to obtain them. This is an example of using the P implicit, permission to try new things. Many women have pelvic floor problems, such as laxity, prolapse, or poor muscle contraction. For these women, instructions on how to perform pelvic floor exercises, often referred to as Kegels, can help strengthen and improve control of these muscles. In other cases, referral to a genital pelvic floor physical therapist for therapy may be appropriate. Of course, the clinician should evaluate all medications the patient is taking that may be inhibiting her orgasmic response and inquire about relationship psychosexual issues that may be impacting her sexual function. There is emerging data on laser and radio frequency. However, these new technologies are not currently approved or indicated for treatment of female orgasmic disorder. Genitopelvic pain penetration disorders include dyspareunia and vaginismus. Treatments for dyspareunia caused by vaginal atrophic changes, part of the genitourinary syndrome of menopause, include non-prescription moisturizers which must be used on a regular basis to improve the elasticity and pliability of genital tissues. Moisturizers maintain vaginal health independent of coitus. In addition, there are many types of lubricants which are used to reduce friction during sexual activity. Patients should be advised to read labels carefully as lubricants have different bases. Only water-based lubricants should be combined with condom use. For women who do not find adequate relief with over-the-counter products, prescription products may be added. Approved medical prescription products for dyspareunia such as estrogen cream, ring, tablets, or soft gel caps may be considered, along with sex steroid vaginal suppositories, DHEA vaginal inserts, or the oral serum ospemifene. For women who are estrogen deficient, these products may also aid in lubrication and arousal. New terminology now considers vaginismus part of GPPPD. It is the involuntary spasm of the musculature of the outer third of the vagina that interferes with sexual intercourse. Treatment typically involves systematic desensitization, a combination of cognitive and behavioral psychotherapy counseling to help a woman overcome anticipatory anxiety about pain on penetration and progressive vaginal dilation. For complicated or long-standing sexual problems or dysfunctions, you may wish to refer patients to a sexual health therapist or a couples counselor for individual, couples, or sex therapy, or a gynecologist who specializes in sexual disorders. Pelvic floor therapy from a qualified physical therapist may also be beneficial. You may decide to refer because you feel you lack the technical expertise to adequately manage the patient, or because the sexual problem is best served by a multidisciplinary team approach. When referring, be sure to normalize the nature of the patient's problem and the commonality of referrals to gain the patient's acceptance and follow through with the referral. You can also recommend books or other resources for patients to consult about their sexual dysfunction. There are many excellent consumer books on the market. Some recommended books are listed here and at the end of the video. In conclusion, female sexual dysfunction is a common problem in the United States, and sexual health is an important component of well-woman care across the lifespan that can reduce the incidence of risky sexual practices, STIs, unintended pregnancies, and sexual assaults. Gaining confidence and overcoming discomfort in discussing and diagnosing sexual concerns is critical to your competence as a gynecologist in the 21st century. You may wish to manage simple sexual problems, or you may prefer to refer all cases of sexual dysfunction to specialists. Either approach is acceptable, as long as a woman receives the help she needs to improve her sexual and overall health and quality of life.